good morning, everyone. It is Tales from the Heart. Welcome. I am Lisa Salberg. I'm your host of the event today. And joining me is Dr. Patient Alex Faria. And I think this is the only place that he gets introduced as Dr. Patient.
Yeah.
So, Alex, good morning. How are you today?
I am good. I apologize for my attire. I am in the hospital and popped out of the hospital to meet with you.
See, that's the beautiful part of Tales from the Heart. We kind of like pull you out of the clinic or wherever you happen to be, and we just have some really great conversations about HCM. And today is May 22nd. So there's a couple of key things that happened on this day in history. And there's something that's going on right now that I want to update everybody on. So 35 years and 2 days ago, I did a thing, and I got married. And 2 days before my wedding, I had a really bad toothache. So I went for emergency dental work. And on this day, 35 years ago, I was landing in California on my honeymoon, and I noticed that I had a numb spot on the side of my face, and it went away. And a couple days later, the numb spot went down the whole side of my upper chest, and then it went away. And then the numb spot turned into a blind spot, and then it went away. And when I got home from my honeymoon, my left hand went numb, and then it went away. And on June 16th, 1990, I had a full-blown stroke secondary to subacute bacterial endocarditis. But 35 years ago today was the first symptom I felt of a transient attack, so a TIA, where I started to feel slight nerve damage from the blood clots landing throughout my body, originating in my heart, caused by my wonky valve created by hypertrophic cardiomyopathy.
Mitral valve endocarditis, right?
There you go. And today you can actually see the thickening on my mitral valve as my heart sits in a box. So, 35 years ago, I went through some stuff. And here I am today to tell the tales. So that's part one. Part two is happy anniversary to my husband, who married the girl who had a stroke within a few weeks. Nothing dramatic there. But he's been through a few adventures with me.
Yeah,
so,
congratulations.
happy anniversary.
I will ask you a question based off that.
Go ahead.
What do you tell folks about being on antibiotics for dental procedures?
For obvious reasons, I explain. Now, this is not a yes or no answer. It's a know your anatomy. And it's one of the biggest reasons why I think people really need to know if they have provocable obstruction. Because if you're non-obstructed, the risk of endocarditis appears incredibly low, not zero, but low. But if you have turbulent blood flow in the heart, which is created by the obstruction and the interaction of the mitral valve and any mitral regurg, if you have anything that causes turbulent blood flow, I err on the side of caution and says use antibiotics unless you have an adverse reaction to antibiotics. And if you have to err on the side of caution to reduce your particular risk, I think you need to do that. This global backlash that happened years after my endocarditis happened of we're using too many antibiotics, we shouldn't use them. I agree. Use them for every cold you have. But when you have an underlying heart condition and you're giving the opportunity for streptococcal viridine to enter your bloodstream through your mouth, I like to protect people from what I went through because it wasn't fun.
I say the exact same thing.
Dr. Patient Alex?
I say literally the exact same thing. Even though the reason I bring it up is because the guidelines would tell you that it's not necessary. And every year I see at least one patient with obstructive HCM either see me acutely with endocarditis in the hospital, I meet them for the first time then, or I see them as a new patient in follow-up from their hospitalization because they now have a mitral valve replacement and were on antibiotics because they had endocarditis. And if you look, they all had obstruction and very abnormal valves and probably some scar that was a nidus or a place for the bacteria to latch onto. So I also prophylax, and I myself take prophylaxis because I've had some work done. But, for all of my patients that have obstruction or any kind of potential abnormal tissue on the left side.
So thank you for the question. And I think the guidelines are wrong here.
But there's variability in practice in the community, even within HCM. So that's why, some people may not agree with me.
And some people may not agree with me.
Yeah.
But I'm going to tell you something, Alex. On this particular issue, I'm the expert. I lived it. And if I could help somebody avoid having lived this particular experience, I would do it. It has long-term residuals that I didn't expect 35 years ago when I was young and I had a stroke. When I had to go get my transplant, they're like, we need a CT of your brain, Lisa. I'm like, it's going to scare you. And they're like, well, we need to know where you're starting from in case something, we need to look at your brain later. I'm like, it's going to scare you. So I gave them my CT, and then they literally are like, you are not kidding. How do you, and they started asking me questions about how I think and how I process information. And they're like, you got a significant brain injury. I'm like, I know. And I don't talk about it much. I don't view myself as a brain injury patient, but I am.
Yeah.
And it's not insignificant. So I have partial vision loss in the one eye. I still get a numbing in my jaw where I don't feel it, it's weird. Just internal, I don't have feeling, and the muscle's a little weak here. My left hand gets weak. My hip gets weak. I'll drag my foot when I'm really tired. So I have these long-term effects, but as I'm getting older, they're getting a little bit more pronounced. So something that happened 35 years ago has consequences today. So just be careful out there. Endocarditis, you can avoid it. And if you can, do it.
Yeah.
My heart was obstructed before the endocarditis. I had a gradient of about 100. And then I didn't have a gradient. So I had therapeutic endocarditis for obstructive hypertrophic cardiomyopathy. Put that all together. I don't recommend the therapy. Highly unpredictable or reproducible. But because my mitral valve stiffened and got a scar on it, it stopped its ability to move all the way to the septum. Kind of bizarre. So anyway, I digressed down the stroke endocarditis rabbit hole that you dragged me through. So thank you for that. I do want to give everybody an update on Esther. Esther is about a week and a half, 2 weeks almost, after getting her third heart transplant. Many of you in the community have been following her story for a great long time. I met Esther and her family when she was 7 or 8 years old, and it's been a really long ride because she's now in her mid-30s and the mother of 2 young teenage children. And her husband, Herbert, has been her hero and her savior through all of this, and he's sitting bedside with her right now. And she is struggling with blood clots in her leg, and they're not sure where this is going to lead. She's been brought back to the OR a few times. This is a very fluid situation, and on behalf of Herbert and Esther's family, they are a Christian family who's very religious, and they ask for your prayers no matter where you are in the world or what religion you practice. That they're asking for prayers and good wishes be sent to Esther because she needs all the help she can get, and she likes knowing the community's behind her. So I'm happy to give that message to everybody and do what you will with it. Other updates, our buddy in Toronto who had the transplant 2 weeks ago, he's doing great. Our buddy down in Florida who waited over a year for his heart, and he's now 22, 23 days post, he's now moved to rehab. So our 3 transplant warriors of the month are on their way to recovery, and we know many more are waiting. So, Alex, it is Medical Management May. And in the world of medical management HCM, we've just talked about antibiotics and how they have a role. What do you think is the most interesting advance that we're looking at today in medicines for those with HCM, cardiac specific or otherwise?
I think that myosin inhibitors have been just a complete game changer in terms of treatment, at least for obstructive HCM. And there's other interesting medicines that are being studied as well that are, myosin modulators, but I think that everything was borrowed from other disease processes to treat HCM up until the last 8 years. And so we weren't doing that great of a job medically managing the condition. And so I would say and I've only been independently practicing medicine now out of training this will be my 4th year. But even during that time, it has changed what I offer to patients the very first time I meet them for their disease. So to me, that has been probably the biggest change I've seen.
So it's change. It's the concept that we're moving people towards. We didn't understand what myosin inhibition even was really 10 years ago, 15 years ago. I guess we kind of started learning about the mechanism in a lab, but getting to the point where people understand it, and it's becoming not only an accepted part of treatment, but almost an expected part of treatment options as they're offered to patients now. And that is a big pivot. It was just basically throw everybody on beta blockers, maybe a calcium channel blocker, have a nice day. And now we have targeted therapies. Amazing.
Yeah. And not just because I used to, in the back of my mind, based off personal experience and then seeing how other people do, I would always say, we can start you on metoprolol or verapamil, and it might make you feel a little bit better. But for my folks that had severe obstruction, deep down I knew I probably wasn't going to make them feel great. I wasn't going to bring them back to normal. And just because everyone has lived with this for so long, even a marginal benefit from being on a medicine like that was great, but they never really felt the experience of having almost complete resolution of symptoms unless they went to surgery or something else. They never felt that with a medicine.
Right.
And now I can say that I have a lot of people that say, I had a patient cry with me last week. He was just like, I never knew how bad I felt. And you told me that before we started the medicine, that I probably don't know how bad I feel. And now he's asymptomatic. And he's a teacher, and he's running around the school, and he can do whatever he wants to do. And that was previously not feasible with a medicine for the most part.
I think it is one of the most bizarre aspects of HCM when you compare it to other diseases that patients don't know how they feel.
Which is why endpoints for trials that ask questions that maybe aren't targeted towards how you feel bad are probably not the best way to gauge how well medicines work in this disease.
Say it again for the people in the back. Yeah. So I couldn't agree more. Let's take a dive into the Odyssey trial, shall we? This could be fun. So the Odyssey trial was for non-obstructed HCM with a myosin inhibitor. And when the trial was designed, I threw up some caution flags, I'm not going to lie, and the people that were at the table know I did it. I'm like, I don't think these endpoints are strong enough because non-obstructed HCM is different. We have spent so much time and money and resources understanding the obstructed HCM population. Even though our name is the same word or minus a word, non-obstructed hypertrophic cardiomyopathy acts differently. It comes on slower, the symptoms. The modifications you make to life are more nuanced, and improvement is more nuanced and actually takes a bit longer to really soak in. And I don't say this from a perspective of somebody who could not possibly understand. I've had obstructive HCM, non-obstructed HCM, and somebody else's heart. Yeah. Okay? This is the most normal I could possibly feel. And I know this isn't even normal, because I still have a transplanted heart. But non-obstructed HCM can be incredibly mild, and you can do almost anything and then pay a price for it a day or a week or a month later because you overdid it and your heart muscle gets kind of like fatigued over a cumulative approach rather than in the moment. And then I don't know how to quantify that with the proper words or a measurement, but you just hit walls and then you have to rest. And after you rest, maybe you feel a little bit better, but maybe you never quite get back to the exercise level that you were before. And that loss of function is so minute. I've likened it to coming into a clean desk every day and somebody put one piece of paper on your desk every day. A day, a week, a month doesn't look so bad, but a year, it's a lot of paper, and you're carrying that. And I know I've seen people who took part in early trials, went into long-term extension trials that were non-obstructed and had amazing benefit. I know the Redwood, and so we go to the API studies. in the non-obstructed. They're showing positive indicators. I'm not sure that the drug failed the non-obstructed population or the trial design failed the population. And I think there's going to be more to learn here. Alex, what do you think?
Yeah, I mean, exactly as you were saying, if you're thinking about something like for the folks that aren't familiar with this or don't think about how trials work or how they're set up or what endpoints are, the idea behind this trial was, can we prove that someone, their functional capacity or their ability to do what they want to do is better based off their symptoms, how they report them from a series of questions in something called the Kansas City Cardiomyopathy Questionnaire. And so then you have to ask yourself, well, what are those questions? And if you fill out those questions and you have HCM and they don't apply to you even before you're in the trial, then the likelihood that they're going to get better on treatment is probably not there. So like some of the questions are like, do you get short of breath walking on a flat surface? Specifically flat surface. And I have a lot of non-obstructive and even obstructive HCM patients that walking on a flat surface might be okay for them. It's the incline, it's the stairs, it's after eating a heavy meal, things get hard. I have a lot of patients that don't have lower extremity swelling, or their legs don't swell up. They would say no on there. I have a lot of patients that, don't get short of breath when they lay flat. I have patients that don't. One question is something to the effect of, does this keep you from doing the things you want to do? And most of my HCM patients will say, I push through everything and do what I want to do, and I've worked my way around it. And so questions like that, I think, will miss symptoms in people. And it's just a much more nuanced disease. And just so you people also know, these scores are what we use for all the other trials, whether you have diastolic heart failure, systolic heart failure, dilated cardiomyopathy, whatever. It's like, just like all the medicines we used before myosin inhibitors were borrowed from other things and didn't work great. This score has been borrowed from other things and doesn't work great. And so I think that, and I'm not saying I know the answer, but of how to create a better assessment that we can use in a clinical trial that the FDA would use and say, okay, I buy this, these people are getting better, let's approve this drug. What I do know is the symptoms that people have. And I think that there is a way, and there's, Lisa's been involved with trying to find ways to better gauge people's symptoms. I think that we need to reevaluate how we gauge symptoms to really adjudicate whether someone's getting better with a drug or not. Because a lot of the markers of improvement that you would expect to see if someone's feeling better, like blood markers of strain and pressure in the heart, improve when they put you on a medicine like this. So the stress on the heart is getting better. And so there's other markers that suggest improvement, and people are saying they feel better, yet the trial didn't show that. It just makes me suspicious. I hope that this isn't like the nail in the coffin for myosin inhibitors in non-obstructive patients. And like you said, it's also challenging because there will be one paper that says that non-obstructive HCM people don't have symptoms and they live long lives and they have no problems. And then another non-obstructive HCM paper will say, no, people do have problems. And they're from very big names in our field that I have tremendous respect for all of them, but completely different kind of approaches to it. And I think that the answer is somewhere in the middle.
Yes. Some patients do very well. Some patients don't. I think we're better at identifying when people are crossing that line of real trouble with non-obstructed. And we've done a much better job of shepherding those individuals to transplant. We used to be less than 1% of the UNOS registry. We're between 3 and 5 now. I don't think we should be much higher than that because most of us do really well long term. But those who don't, we know transplant's an option. But non-obstructed is not non-symptomatic. Non-obstructed is a different physiology. Why would you expect the same symptoms from somebody who's not getting blood flow out of their heart to somebody who just has a stiffened, non-compliant, tired but stiff ventricle.
Yeah.
You know, as you get a little older and all those joints start to stiffen up, same thing with our hearts in a sense. They just get a little tight and stiff. So I think there's something in a myosin inhibitor for the non-obstructed population. I think there's room for us to learn a lot more about how to define the non-obstructed patient journey. And, you know, Alex, you're now in the professional care of patients. You're also a patient. You know the difference between being obstructed and non-obstructed. It's different, but it's not perfect where you are now. And like some of the limitations and the symptoms, they're not in our current vocabulary to define.
Mm-mm.
We don't necessarily have the right point to, and I'm thinking through this now, which is probably a really bad time for me to go down a rabbit hole while I'm live on a podcast. So I'm going to kind of pull myself out of that rabbit hole. But we're used to using the words in the obstructed curriculum. And we're trying to make those words work for the non-obstructed because they're in our vocabulary. But the types of symptoms I felt as a non-obstructed person, there was a lot more cognitive involvement. I got fuzzy-minded when I was tired, and I just couldn't put thoughts together. And I just thought, I'm tired, but it was beyond just I'm tired. There were symptoms of a dizziness that was different than obstruction-related dizziness. And was it dizzy? Was it lightheaded? It was more neurologic. It was more focus. And like, I'm just not feeling oxygenated. And my muscles would get weak and tired. So I would rest and I wouldn't do as much. And these were subtle. And then they became all encompassing. And then I got a transplant. Yeah. So how do you balance that? How do we talk about it? We need to do better here at HCMA to talk about it. We need to find those words and those experiences without leaning into the words that we're already using for obstruction. You see what I'm saying there?
And, you know, I saw that I might have been Ross popped up the question, what symptoms do you experience? I mean, I think that we have to kind of go back to the basics and listen to what people are saying. Like, if you got every non-obstructed patient in HCMA to say, what are your top 3 symptoms? They may not be even close to what an obstructed patient would say their top 3 symptoms are.
Right.
I'm pretty good at figuring out symptoms from an obstructed patient. I am not great. And I ask questions, and I'm a non-obstructive patient myself. Now, I'm not great at finding them for non-obstructive HCM. And I do this all day. So it's a tough population.
You're doing it all day. I've worked with over 20,000 families over almost 30 years, which makes me sound really old. And they're even using the same language as obstructive patients use because it's what they've been given to work with. And maybe it's the expression of the non-obstructed symptoms. We just need to word chart out. Like, what are the words that you're feeling? Just don't look at the words that exist. Like, what do you feel?
Yeah.
And maybe we can do a better job there.
Yeah.
Maybe we can do a better job there. So, okay. So that's another rabbit hole for the day. You have an interest. I just want to, Stephanie, you got a very large question there. And that's a genetics talk that Alex and I could go on for like probably 2 podcasts. It's a complicated family history with multiple genetics. It's probably sounding like some VUSs and some pathogenic, but we're not getting to clear answers. That's when you need to go to a high volume HCM center, meet with a high volume team and a geneticist and sit down and put it all together. And you might have to look for, you know, if you went to one team and you're not getting answers, maybe we can bring in another team to try to get you some answers. But that's a very complicated issue. I don't want to ignore the question, but it's complicated and we're happy to try to help you find resources. Okay. No, I'm glad that you dropped the thought, and I'm glad that you shared it with us, and I'd be happy to follow up with you on that later. So going into the issue that's near and dear to your heart, GLP-1s. Let's just talk a little bit about what do we know and what should we learn more about with GLP-1s and HCM.
So I brought this up earlier. I don't know if there are any randomized trials going on with GLP-1s in hypertrophic cardiomyopathy. Someone will do it. I've been saying we need to do this for years. What is clear to me is that obesity makes the outcomes in this disease worse. And perfect example is my brother and I. My brother weighed, same genetic makeup, weighed 350 pounds for many years and passed away from HCM in his 30s. And I see it all the time with my patients, and I tell them about my brother because I'm like, we can't let this happen to you.
Right.
And whether it is just the strain on the body, an HCM heart, the energetics, the way the heart works, the heart's working harder than it needs to already at baseline. So then imagine carrying a 150-pound book bag every day. And that's what it's like being obese with HCM. And so and we published on this when I was at Vanderbilt with Jason Becker, who's one of the HCM guys at Pitt. We published a paper on this. And Charlene's published a paper on this. It's a known thing that obesity makes it worse. And so there's lots of data on GLP-1s now with people losing significant amounts of weight and the benefits on blood pressure, the benefits on cholesterol, the benefits on diabetes. It was a diabetes drug first. And so I anecdotally have had patients on GLP-1s that have lost a lot of weight, that are non-obstructive, that have felt significantly better. And so I think if I weren't so busy seeing patients, I'd be doing a trial on that. And if there's a cardiologist listening to this, they're probably going to do it as soon as they hear it, because, I think it makes a lot of sense. And the other side of that coin is that for years we told people with HCM not to do anything, which was not the right counseling, but we did. And the handout that I got when I was 16 was a picture of all the things I could do, which the highlights were bowling, golfing with a cart,
rivalry and archery.
Yeah. It was that box with the picture of the guy and it was terrible. And so how do you expect someone that already doesn't feel great, and then you tell them that they can't do anything, to not gain weight and then spiral? And then there's the whole depression aspect of the disease. So it's like, this vicious cycle that leads a lot of my HCM patients to be overweight or obese. I would say the majority of my patients are at least in the overweight category. And so, if you're too symptomatic to exercise, then it's hard to lose weight too. So what I've been doing personally is if someone comes to me and is overweight or obese, and we try as much as we can with diet, exercise, lifestyle modification, sometimes I've been using GLP-1s as a kickstart, not as a lifelong plan, because one, I don't know what the long-term being on a GLP-1 looks like. No one does. And, two, I think that lifestyle changes are what's permanent, not a medicine that for insurance reasons or whatever you can't be on.
Right. But
a lot of my patients are on those and on mavacamten as I'm trying to change, their whole life.
Is that all? Is that what you're trying to do?
I'm trying to change how they feel. People have been dealing with this for years. And so I think that is one area that no one's done. And in probably 5 years, when it gets done by someone that has more time than me, you can say, oh man, that guy was really smart. And I can say, oh, I told Lisa.
So I want to tell you what happened as we were talking. Did you notice? I was looking down for a little bit. I was texting a friend of mine who happens to be in a really well-suited position to possibly make some connections for me and you within a company that might be able to help us do a GLP-1 research project. So yeah. I just literally sent the text. So let's see if we can get something moving here.
Yeah.
People wonder how the work of patient advocacy happens. It's because of connections and people. So you have an idea. We know the people who are doing the research on the other side, but bring the researchers together with pharma. There's patients that are interested. We already have patients on GLP-1s. Maybe we just do a search and see what it's looking like. Yeah. Maybe there'll be a formalized trial, or maybe we could even go for real world label indication if we have enough data. How do we make sure people can get what they need and we scientifically prove that it works?
Yeah, and I'm having a hard time getting my patients on GLP-1s if they don't have diabetes, just for the indication of obesity, even with the added risk factor of having heart disease. And so that has been a challenge to get folks on drug. But,
well,
can't fix that.
We have somebody commenting in about being on the combination of a myosin inhibitor and a GLP-1, and it's life-changing. It's transforming lives. And this is the amazing thing about science and technology and where we're going. It doesn't mean that we can have, bad personal habits. We need to take personal responsibility. But sometimes our metabolism is chemically responding differently, and it's telling our brain one thing and the reality is something else. And these GLP-1s, I'm watching it firsthand. My husband has just completed a clinical trial. He is a type 2 diabetic. He did the clinical trial for the oral version of the Eli Lilly GLP-1. Mm-hmm. And he just ended the trial last week.
Okay.
He lost about 35 pounds on the trial. His A1C came down 1.5 points. He is not labeled diabetic at this moment. So now the trial is over. He has been on this medication for 1.5 years in a trial. He is now at this exact moment not diabetic. Now I need to go bring him back to his diabetes team here and go, how do we keep this as it is? Because at this moment he doesn't look like a diabetic, but he got the medication that's no longer available because the trial's over. And I didn't think about that at the beginning of the trial. There is no extended trial. There's no extension, and it's not on market yet, so you can't get compassionate use. And it won't be available till 26 plus. Yeah. So I've seen in my home GLP-1s work, and quite amazingly, my husband's always kind of been challenged with his weight, and nothing could get, even his good habits and exercise and everything else, he wasn't dropping. This helped him drop the weight and get everything under control. I'm just hoping that it has some longevity to it.
Yeah.
So I think there's something there. Let's see what I wish I had. See, Jeanette wants you to ask her doctor. But at least you get to hear him on Tales from the Heart, and you can get his insight.
Come to Philly.
Come to Philly. Come see. Yeah, it's a lot to do in Philly. It's a fun town. And it's right by the train station, like right there. You don't almost get much closer for any other center. All right. So, Alex, as we are chatting about medical management, what else do you want people to know about medical management of HCM in 2025?
Yeah. Well, I think it's a crime for people to continue to live with treatable symptoms. So I think if you feel, kind of getting back to what we were talking about earlier about symptoms and asking the right questions, if you feel bad, but you feel like you're not being heard, like, but especially like non-obstructive is kind of like what you were saying with joints earlier. You go to someone when you're 40 and you say, my knee hurts. It's like, well, you're getting older. And so same thing with non-obstructive. Like, well, you don't have obstruction. I don't see why you feel bad. I think if you're not being heard, keep looking and finding someone that will hear you, because there are treatments, whether it is FDA approved, whether it is clinical trial based. I mean, right now we have, so a lot of the myosin inhibitor trials, like for mavacamten, aficamten, that's been winding down and not enrolling, but we do have other medicines that are being either actively used to treat obstructive or non-obstructive HCM. And so if you go to big centers that are participating in clinical research and trials, there could be an option to treat you that you may not be offered somewhere else.
Correct.
And so I would say keep looking, read in the HCMA. All the ongoing trials are available. Like, you have them on the HCMA website, right? Any active ongoing trial is listed, aren't they?
Any trial is listed, and even more so, we have something called an antidote filter. You can answer a couple of questions. You don't have to put any names in. You could just look at it anonymously, and it will tell you what clinical trials, based on those answers, you may qualify for. You can do that at any time, 24 hours a day. You can do it at 3 o'clock in the morning, and it'll give you a list, and it'll give you a distance, and it'll give you some information. We are actively recruiting for Sonata HCM here at the HCMA, and that's a project with Lexicon. You want to talk a little bit about that trial? Because you're one of the sites.
Yeah, my colleague, Dr. Day, I think this was kind of born out of some of the ideas. When I first mentioned my GLP-1 idea, she mentioned her idea with this, and she's a researcher, so there's an active clinical trial going for what she's doing, and she's brilliant. She's one of the best HCM cardiologists in the world. And so the idea, if you hear like the commercials for Jardiance and other medicines like that, those are SGLT2 inhibitors. This is slightly different. This is a drug called sitagliflozin, which is a combination of SGLT2, SGLT1. Those are a lot of letters that describe essentially a medicine that's it's complicated in how it works and how it helps people feel better for various different conditions. It can be used in diabetes. It can also be used in other forms of heart failure. But one of the ways it works is that it helps with getting sugar out of the body by urinating out sugar. It also has some effects on your GI tract when you have the combined version, which is sitagliflozin. But the idea being that can a medicine like this in either, I think Sonata is both obstructive and not obstructive.
Correct.
There's another one called Sotacross, which I'm not sure if you're involved.
We're not doing that one.
Yeah. But so non-obstructive versus obstructive HCM, could this medication help you feel better, maybe relieve some of the extra fluid that you might have on your body? Sometimes my patients with non-obstructive HCM that are on Jardiance or medicines like that actually have some improvement in their symptoms. And so the idea is to try and do a randomized trial for both types of HCM to see if people have benefits. What I will say is that medicines like this have shown significant benefits in many other forms of heart problems. And so I think it makes sense to try it in HCM. And so that's actively enrolling. Lisa's been working hard to try and get people in this trial. And I'm not sure about how many sites there are. There's probably a link.
There's 17 or 18 sites right now that are open in the United States, and there are a couple more that are in contract, and they'll be coming on board over the summer. Should be mostly all done by June. And then as those sites open up, about 150 of our members and followers have already given us consent to send their information to the sites through a survey that we did. Mm-hmm. There were some little technical glitches on the back end, so some people didn't get called back yet, but they're still going to receive communication back from the sites. Mm-hmm. And we just sent out a follow-up survey. If you see it in your inbox, please take a moment to do it, to say, okay, what you told us back in February that you were interested in doing, everybody's ready to hear from you now, so let's just make sure you're still ready to do this trial. So if you got that email, please fill it out and send it back. We've already gotten maybe, a quarter of you responding since last week. So let's hear from the rest of you and get that moving, because, if you're already on Farxiga or Jardiance and you did put your name into that survey, they're not going to let you come off of a medication and then do the trial. At first they said, oh yeah, we can do that, but it's really a pain in the neck, and your insurance companies may have issues with you going on and off a medication because there is no long-term extension trial here. So we want to just keep you guys on whatever you're taking. And for those of you who wondered, is one of those drugs appropriate for me, is, Farxiga or Jardiance okay for me? This might be a trial that you want to talk to your physician about investigating and possibly joining, because it will get you onto the drug sooner, and you'll see if it works for you. And if it does, after the trial is completed, you do have another option that's close to it, which is one of the other GLT-1s. This is the GLT-1-2 combination. Did I get that right?
That's
GLT-1
okay. Combination. Yep. And I also think you can be on a myosin inhibitor.
Yes, you can.
As long as you're symptomatic. I don't think you can be completely asymptomatic.
If you are still having some symptoms and you are on a myosin inhibitor, you would qualify for this particular trial. And that makes this the first clinical trial that I'm aware of that's allowing Camzyos as a background therapy.
Yeah.
Which is kind of cool. It's kind of cool. I like that. So Alex, can you help our listeners understand a little bit about cardiorenal connection? Why are the kidneys and the heart so intertwined, and why might a mechanism like a SGLT1-2 help somebody with long-standing structural heart disease.
Yeah. So, if you talk to a nephrologist or a kidney doctor, they will argue with you about the importance of the kidney versus the heart and vice versa. I do this all day with kidney doctors, but the kidneys, they regulate a lot. They don't just make urine. They're not just there to help you pee and clear out stuff from your body. They control how much fluid you're retaining in your body. They can control aspects of what causes your blood pressure to go up and down. They can control the response of your heart to different things in your body. So there's a lot of interplay between how the kidneys and the heart work. SGLT2 inhibitors, SGLT2 stands for sodium glucose-like transport. And that is a little pump within the kidneys that helps pump out sugar into your urine. And so that sugar then draws in fluid, and you kind of get rid of some fluid and some sugar in your urine, more than you would otherwise. And so that's why if you were to look at someone's urine that's on an SGLT2 inhibitor, you will see more sugar. That is one of the reasons why there is a slight increased risk for infections in the urine or in your urinary tract, is because bacteria like sugar. But the idea initially was, let's see if we can get people to pee out more fluid and more sugar and see if that helps decongest their bodies. I think that the mechanisms behind how these medicines have helped with heart failure are much more complicated than that. And most people think they're more complicated than that. But there is some component probably of decongestion of the body with these medicines, taking out extra fluid. So when you have a condition like HCM and a very thick, stiff heart that maybe isn't as efficient as pushing blood forward and can have some buildup of pressure and fluid in the body, then kind of enabling that with a medicine can be beneficial symptomatically and for the heart. And so it was honestly one of the reasons why I wasn't sure how people with obstructive HCM were going to do initially. And I'll be interested to see how they do with SGLT2 inhibitors, because this trial enrolls both. If there is even a small component of decreasing the filling of the heart with a medicine like an SGLT2 inhibitor, we always talk about how decreasing filling of the heart in someone with obstruction can make them feel worse. But I think it'll be interesting to see how people do, because it's more complicated than that. And so, but all that being said, there is a lot of interplay between kidneys and heart, especially when the heart doesn't do well, the kidneys a lot of times don't do well either. And so the fact that these medicines help keep the kidneys strong is another benefit if you're a heart patient.
I think we don't talk enough about having multiple disorders or comorbidities and how one could potentially lead to the other. There's something I don't talk about a ton, and that's the mechanism of my dad's passing. My dad didn't really die from hypertrophic cardiomyopathy. He died with it. My dad died from kidney failure. And that kidney failure came on from something that unfortunately was a bit more common when he was facing problems. So my dad had bad arthritis. So he lived on Tylenol until ibuprofen came out. And then, we just kept amping up the NSAIDs and the Tylenol, and my dad burnt out his kidneys with over-the-counter pain medication. So be careful with your over-the-counter pain medication, because it can have long-term consequences. So his heart was always a problem. He had HCM. He had mitral valve repair in his, about 70 years old, but then the kidneys took a hit. So the interplay between your kidneys and your heart, it's always a challenge. And then if the kidneys take a hit, it's hard on the heart and vice versa. So your kidney health is important. And I encourage us all to stop and think about that a little bit. We think about our hearts a lot more in this community. We don't think about our kidneys enough.
Yeah. I mean, most of us do not have the luxury of being able to take a second hit, and that's why I talk about the weight loss and the diabetes management and the high blood pressure management, all that other stuff, because, you're already working uphill when you have HCM, and you just don't want to add second problem or third.
So 2 other topics I'll bring up while we're talking about kidneys and other things that we put into our body. So last weekend I was in Geneva at the World Heart Federation Summit, And there were some really interesting talks about issues beyond HCM or global health issues as they relate to heart health. It's such a sad topic because it's one of my favorite things, as with most of us. Sugar. Sugar's the devil. Sugar's the enemy. I love sugar. I have a toxic relationship with sugar myself, but God, looking at all of the negative health consequences that come from sugar and how, especially in America, we have figured out a way to put sugar everywhere. Look at labels. Ketchup, salad dressing. We're putting sugar on meat.
Yeah, deli meat.
We're putting sugar on vegetables. We're putting sugar on everything. This weekend, as you go off for Memorial Day, I want you to take a minute to keep in the back of your mind how much sugar you think you're eating by the candies and, the cupcakes and the fruit, the watermelon that's in season, finally. I love watermelon. Look at all the different ways you're getting sugar. If you're getting it from fruits and vegetables, you're also getting fibers, which help your body process those sugars. If you're taking it off the shelf or you're pouring it on something or in something, it's not normally binding with anything else, and it's just overloading your body with sugar, which causes inflammation. And sugar equals inflammation, and inflammation is horrible for us, just horrible for us. There's no good parts of inflammation. So sugar leads to inflammation. Sugar is the devil. That is what I got from the World Heart Summit.
Yeah.
What do you think about that message?
I mean, it's unfortunately, and I grew up in Georgia. I love Coca-Cola, but soft drinks, things like that, it's tremendous amount of sugar. And it's funny. One of my patients one time told me they did this diet called the Whole 30. And they're like, I lost a bunch of weight and I feel way better. Like from an HCM standpoint, I lost 25 pounds, blah, blah. So then I looked into the diet and I was like, I'm going to try and do this. So Whole 30, there's no added sugar to anything. So it made me look at every single thing I ate. It's called Whole 30 because you do it for 30 days. So I looked at every single thing I ate, and it is so restrictive. If you were to look, you essentially have to, anything you buy can only really have 3 or 4 ingredients, because almost everything has sugar added unnecessarily, right? Like, I remember I was like, I'd like to try some bacon. Let's see. And not saying that bacon is great for you, but I was like, let's look and see if I can find a bacon with no sugar added. And at Trader Joe's, I was able to find one. You got to go to the butcher.
You got to go back to the butcher.
Sugar is in everything. And so, diet is such a huge part of this. And I will be the first to say, like, if I had infinite funds and no restrictions, I would make a nutritionist I would have one embedded in our clinic. That then it almost should be like, see the nurse, see the genetic counselor, see the nutrition, see the doctor.
Yes.
We don't have that yet. Yeah. Maybe one day I'll have a donor that just says, you know what, Alex, here you go. Take all this money and make the ideal HCM clinic. If I could, that's what I would do. And psychiatry, or not psychiatry per se, but therapy.
So while you bring that up,
other prong to the clinic.
And you gave me, another thought bubble to go build a new project over, because thank you so much. I need more. But I will put out a soft notice that we are building something. We are building a mental health network. Oh, it's going to be called Hearts and Minds. And we are working in partnership with Dr. Sam Sears, who's a psychologist who specializes in device patients and cardiac patients as a whole. And he has trained a little group of fellow PhDs in this space. And we're going to organize that network much like I organize the concept of HCMA Recognized Centers of Excellence. But this will be a Hearts and Minds mental health program. It's going to be an accredited course that we're going to build to teach therapists what it is to treat HCM patients and other genetic heart muscle disorder patients. As a core, that's where we're going to learn, but then it will go out to the congenital heart disease community as a whole. And then I had the epiphany last night we're focusing this first. We put in a grant. I'm not saying where or the details yet, but we put in a grant for this, and it's for people under 25 for mental health services. That could be the patient, or that could be the child of a patient. So there's different people that can be involved here. But we are going to build that out so that when you have somebody in front of you, Alex, and you say, I really wish I had a therapist that could meet them virtually, that really understood their needs, we're going to have a list of vetted therapists. There'll be psychiatrists, psychologists, therapists, and even down to the people within your hospital from social services and I just lost the word of the profession, I'm so sorry, social workers, and then we're going to do a peer-to-peer element as well. So over the next year, we'll build this out and give you the opportunity as a physician to find better resources without having to dig and wonder, is this the right match? Do they understand a cardiac patient? We're dealing with PTSD from medical trauma. We're dealing with generational grief. We're dealing with the guilt of genetics. We're dealing with issues that not every therapist is going to understand. So we're going to teach them. What do you think?
I think that's great. And then it can be in the after visit summary as a link for every HCM center of excellence that people can take
Exactly. So then you brought me into nutritionists. Let me see if I can do the mental health network. Then maybe we can build a nutritionist network.
I love that.
Okay. So community that's listening, we are a constantly evolving community. And each and every one of you brings skills, experience, and lived experience that might help us in these endeavors. Over the next couple of months, you're going to see us starting to offer volunteer opportunities in time segments. What can you do in 15 minutes a week to help the community? Might be sending some letters out via email on different topics, whether it's to a local hospital, an elected official, a school system, whatever. We're going to give you all those tools. But as we do this, we're going to be getting more people that are going to come into the network because more people are going to get identified. So we need to get smarter in how we're offering services to support everybody through that, and everybody can help lift this. So you're going to be given different opportunities to do so because it's really important that we all get the services we need. And I'm sorry, Alex, I have to go down a path just for 1 minute. The loss of Medicaid coverage to this community is going to be devastating, and I'm going to state an uncomfortable truth as a consequence to those actions. People within our community will die sooner. And it's not political slanting. That's not trying to be hyperbolic. If you remove health care from 9 million people and they're left to cash pay for everything within hypertrophic cardiomyopathy, do the statistics. There's thousands of us in that 9 million, and they're not going to get their defibrillators. They're not going to get their myosin inhibitors. They're not going to get their beta blockers. They're not going to get their screenings. They're not going to screen their children. Their children are going to be at risk. The downstream cascade consequences are apocalyptically bad in my view. What do you think, Alex?
I wouldn't say that people are currently making decisions based off long-term downstream effects. Unfortunately. Yeah, I mean, I have plenty of patients on Medicare and Medicaid that have been able to get therapies they would otherwise never be able to get on. Be worried, and not just the patients, but imagine it's for parents of patients, and like not being able to get their kids insured, and it is. I don't know what we would do for some of this population, but it would be devastating.
We're working with developing up some new children's hospitals into the network. One of those hospitals, I'm not going to name names at this point, 70% of their population is Medicaid. And they are in a southern state that is actively working to remove that coverage from those children.
Yeah. And there's already, a lack of HCM care in that part of the country to begin with. And so if you can't even get your foot in the door to see a primary care or just a regular cardiologist, the way you're ever going to make it to specialty care, gotta lobby.
So I encourage you to contact your senators, your federal senators, because that's where this is going to live now, and tell them what you think. Tell them how you feel. Tell them how it's going to affect you and your family. If you're in support of these initiatives, go for it. Call them and tell them you're in support. But I'm going to guess if you're listening to this podcast, you actually care about people. and you care about people's health. So if you care about people's health, call your senators and ask them not to put the lives of 9 million people at risk. Okay. So I got off of that soapbox, but it's important, people. This is pivotal times. Get out there. Alex, what else do we have to say about Medical Management May? What else is going on out there? What do we need to know?
Something that's come up recently. I've had patients ask me that have HCM and are on treatment, but also struggle from mental health issues about, can I take SSRIs or other medicines that come up to treat that? Absolutely. Some patients are, for whatever reason, and doctors, when they hear HCM that are not in the space, get very spooked by HCM. Like, oh, yeah, cardiologist, and you can't take this and you can't take that.
So the other piece of our mental health network that we're building will also provide those individual providers with some resources that will be available for them to, how do I safely treat an HCM patient in this cardiac space? Now, they may have other disease specialties that we build out from that, but we're definitely building a how to treat an HCM patient model with, scientifically valid psychiatrists, psychologists, endeavored training programs on what's right and what's wrong. And I think that's going to be helpful to save you guys some time in the office, that once you know it's a trusted resource, you don't have to take the time to clear them all. The doctors will feel more comfortable with what they can prescribe.
Yep. So there's other comorbidities that come up with HCM, medical management we got to treat. Things like arrhythmias, AFib. Recently I've been seeing a lot of my patients. I have lovely patients that come from Maryland and come from Delaware and come from New York all the way here to see us. And I'm fortunate that I'm surrounded by an army of electrophysiologists that are very good. Those are the electrical doctors that treat abnormal heart rhythms and do devices like ICDs and things like that. And so I've gotten to see the approach for treating certain arrhythmias medically in a way that other places, maybe in the community, do differently. And recently what I've been noticing is a lot of my patients are getting put on multiple beta blockers like Sotalol in addition to the stuff we usually use to treat HCM, and they're feeling bad, because you're just pounding them with beta blockers. And so, they're just ask about alternative medicines to treat abnormal heart rhythms, because I think some are better for HCM patients than others. Like medicines like amiodarone, great to treat abnormal heart rhythms, probably not great for someone that's in their 40s, because these medicines have side effects and other issues. And so, being involved with an electrophysiologist that sees HCM and knows the different options to treat that maybe won't exacerbate symptoms of HCM, but will keep you out of the abnormal heart rhythms. Like we use a medicine called dofetilide or Ticastin a lot. It's pretty good at keeping you out of AFib. And as long as your heart rhythm stuff looks fine with it, all my patients do great with it. And they don't have the side effects that like Sotalol and other medicines or amiodarone. And so I've noticed that recently that I've been trying to, I usually don't change people's antiarrhythmic medicines if someone else is prescribing them, but I subtly suggest to consider alternatives. And then the other part of that is the anticoagulation. A lot of my folks are, back in the day when it was just warfarin or Coumadin, that was a real pain, and I can get it why people wouldn't want to take it. But, living on blood thinners is not awesome, but it is better today than it was 20 years ago. And the alternative, as if you were here earlier in the talk hearing Lisa, not saying that a blood thinner would have changed her outcome because she has a different reason, but having a stroke is devastating. And so, take your Eliquis, your Xarelto, or whatever blood thinner that they prescribed you. So just I guess the point of the medical management May is just to make sure that every single aspect of this disease is really being appropriately managed medically, because things can go awry if you're not on the right medicines. And there's usually a way to tweak things to make you feel better.
I think we have a lot of tweaks in the toolbox now. There's a lot of things that we can pull out. AFib management has gotten better. The ability to ablate certain arrhythmias has gotten better and more precise. The ability to treat medically has gotten easier with side effects and easier turnaround of anticoagulation. There's a new anticoagulant on its way out. I'm trying to get them to do a cohort on HCM. They haven't done it yet, but I think there's some room to include us in some cohorts in the future, or I don't know, we'll hope. But when it comes to market, we could potentially be an off-label use if we can prove that it's safe. So there's new options coming. My sister and my dad were both on blood thinners, and it was difficult for, my sister was in her 30s and she was on amiodarone and a blood thinner. I mean, that was rough. That was a lot for a young woman, and it got really complicated back in 95, and nobody really knew what to do with her. And if you go back and you look at why, I was talking about my dad's today, I was talking about my sister for a minute. She did not die from HCM. She died from medical complications related to amiodarone, Norpace, furosemide, and torsemide.
Yeah.
So she dropped her potassium, and that caused her arrhythmia because she was medically mismanaged. That was 1995. We're smarter than that now. We don't do these things anymore. We learn from the things that have happened in the past, and we make it better for the people in the future. So medical management is not something to be taken lightly. It can have negative consequences if you do it wrong, which is why high volume Center of Excellence care is critical to patient management with HCM. I will say that every day, everywhere, every time, because I've seen it happen. And you, my dear, were a beneficiary back in the day and now a partner in crime in current. Alex, what are your observations over medical management since the first time you heard the words hypertrophic cardiomyopathy? How far have we really come?
So the way we counsel people on activity level and lifestyle is totally different. The way we counsel people on the impacts of genetics is totally different. What we offer to patients medically at their first visit, regardless of what level their symptoms are at, is very different. And options for sudden death, risk assessment, and devices, totally different. Back when I was coming around, all you could get was a device that put a wire in your heart. Now we offer 3 different types of ICDs, 2 of which don't go inside your heart at all. And so for young people, there are lots of options and older people too, but for the younger person that has to live 60 years, hopefully, with a device, it's a little bit of a bigger decision when you're going to put things inside the body as opposed to something outside subcutaneously. So that's another thing, right? That didn't exist when I was coming around.
Nor I.
Almost every single aspect of HCM care is different than it was in 2004 when I was diagnosed.
I would agree with you. I was trying to think back 2004. Alcohol ablations were all the trend. Everybody thought if you did an alcohol ablation, everybody was all better. How'd that work out?
Wouldn't work for me.
Nor I. It worked for some people.
It does. It's a great procedure in the right person. Exactly. I sent 2 for alcohol ablation in the last month.
And there's still a role, but it's not the answer.
And there's even advances with catheter-based procedures that I think are interesting, that I want our interventionalists to get involved with to learn how to do them, because I think we should be able to offer every single option that could be helpful to our patients. And so even that's evolved. So it's unrecognizable, I think. I used to, when I was in college, I went to the University of Georgia, and I would walk through the library when I was studying for the MCATs, reading the books about HCM, and I think about what the books had then versus now, and it was impressive how much they knew about it then, but it's been leaps and bounds where we've gotten to now.
So I'm going to take that as a segue into this. Tonight is an episode of the Big Hearted Warrior Tour, and we are featuring Aurora and Milwaukee, where legendary, epic Jamil Tajik is practicing. He's partially retired now. For those who don't know, Dr. Tajik used to be the chief of cardiology at a little place called the Mayo Clinic. And when he retired from Mayo Rochester, he went to Scottsdale, did some time down there, oddly got called back north for the cold weather that he missed. Don't understand some people. But he helped develop the program in Milwaukee. And if you look back in your history books on hypertrophic cardiomyopathy, many of the early papers on echocardiography defining the original, appreciation for what the anatomy was, you're going to see the name Jamil Tajik over and over and over again in those early papers. Obviously, we see Barry Marin, you see Pravin Shah, you see all these other names, but Jamil Tajik is right up there. He helped us understand what the anatomy actually is in hypertrophic cardiomyopathy. So if you want to come join him tonight and hear some sage wisdom, 7 p.m. is the webinar, and you can sign up at the website at any time. We've got about 125 of your close friends joining us, so come on in, and it'll be a fun night. And I will be sitting right here in a number of hours doing that exact thing, sitting here with a microphone and talking about HCM. So I encourage you all to join us tonight for the webinar. And I think what we're saying here about where we've been and where we're going, it's a good time to think about both, right? You can't get to where you want to be unless you respect where you've been and what you've learned going through it all. I think there's some lessons to be learned for HCM in our future, and maybe a few for our country too.
Yeah, and we're still moving. This week at Penn, I don't know if you guys saw the article about using gene editing to potentially cure a fatal disease in a baby. That was at CHOP right across the street. There has been data with cells and with embryos, not in humans yet, with using gene editing for things like HCM. And we have gene therapy coming, and it's already happening, gene therapy. And so there's a lot that's going to change in the next 15 years.
I think there's a lot that's going to change in the next 5 if we do it right. But I think if we are short-sighted in our funding of research, private sector and public sector, we need to keep moving forward. We spent billions of dollars figuring out the genome. We are at the precipice of using that investment to cure diseases. We need the ability to cure the diseases and bring those cures to people. If we can cure genetic diseases, we remove those individuals from the healthcare system in the way that they were previously using it. We are now managing their good health rather than a very typical, the first genetic therapies are going to be happening in diseases that have fatal consequences or potentially fatal consequences. And this is where some people with gene therapy and HCM have kind of come in and said, but HCM doesn't have to be that bad in everybody. But what if you could make it just go away? I'd rather it just go away if I could make it go away. Whether you're minimally affected or severely affected, why wait to see where the dice land? Why not? Right now it's risky, it's new. There's clinical trials. Our friends at Tenaya are doing their MYBPC3 trials. We've spoken to other companies who are looking for PRKG patients to join studies. We have people looking at other genetic markers in HCM and other cardiomyopathies. Right now, we want to find the right patients to prove concept on, but at some point, wouldn't it be nice if we could just say, oh, you have an identifiable gene, we'll give you this injection and it goes away. We're not there yet. Don't quote me that we're there yet, but damn, wouldn't it be nice to be there?
Yeah, what they did for this baby across the street this week, I think 5 years ago, they would have never imagined that we would be able to do that. So,
can you give everybody a little bit of a view of what happened there as we come to conclusion today? I don't know that they know the disease state, and maybe we can talk a little bit about that.
I honestly don't know a whole lot about the disease the baby had. It's a condition, a genetic condition where I know that the baby was building up a lot of ammonia, and it's not compatible with a long life, and a lot of kids end up needing a liver transplant. But it was due to a change in one specific gene, and then they were able to go in, gene edit it, and the ammonia levels dropped significantly. I think the child got 3 different rounds of therapy to completely replace the abnormal copy of the gene with a normal copy to then produce a normal protein that worked as it should. And so the baby got to leave CHOP. And that was Kieran Musunuro, who's our scientific medical director for the Inherited Heart Disease Program at Penn on the adult side, and Jenna Ahrens-Nicholas, who I work with a lot because every month we have meetings with the CHOP Inherited Heart Disease group. And so we talk about kiddos with HCM and other forms of genetic heart disease and how they are going to transition to see us on the adult side. And so Dr. Ahrens-Nicholas is a geneticist at CHOP. And so part of our team was involved in that, and it's in the New York Times and all the different news outlets, but it's just incredible to think about where we are, like in terms of what we can do, like the improvements in detection of disease, treatment of disease, and eventually prevention of disease.
It's mind-boggling, and for those who may have been putting pieces of the puzzle together because you follow Tales from the Heart, we've spoken to Dr. Joe Rosano, who is a pediatric cardiologist at CHOP, about the Danon trial and his involvement in the dosing of those with Danon disease for a gene therapy, which Danon is one of the HCM spectrum disorders. So, A, CHOP is doing amazing work in the field of genetics. B, that baby, I think, made so many families smile. So many people think about the hope that's available for gene therapy, and just that little one is going to have a healthy life ahead because of technology that even just a couple of months ago might not have been available for this baby at this time. Yeah. So, mind blown. Mind blown. Okay. So as we wrap up today, just a couple of other comments and reminders. A, we are having our webinar tonight. B, there is a whole bunch of new opportunities coming up to you, so stay tuned for some of our newsletters. We don't like to just send tons and tons of newsletters, but when you start to see new stuff coming in about opportunities to get involved, take a look. We're going after a slightly different approach here. We know everybody's time is limited, so we're trying to find things that we need to get done here at the office that with just a little bit of help, 10, 15 minutes a week from people, we could lift a lot more weight with a lot less effort on everybody's behalf. So take a look for those. Annual meeting coming up in October, opened up now. You can sign up October 18th, 19th, that weekend. We're going to be having a patient education meeting, a medical education meeting, simultaneous. Then when the med ed leaves, we flip that room and it turns into Unmasking the Great Masquerade Gala Part 3. So come and enjoy and have some fun with us, raise a little money, share some stories, get enlightened, and then don't drink too much because the next morning is the first ever HCMA Big Hearted 5K. And that's going to be on Sunday. You can walk it, you can run it, you can volunteer at it, you can cheer people on. It's all going to be in Morristown, New Jersey. It's going to be a great weekend. We're looking forward to having many of you join us. It's nice to be around your big-hearted friends. It's nice to learn together. But this year's meeting is going to be different. It's, yes, going to have some education, but it's also going to have some opportunities for interaction and action. This isn't going to be a didactic, the doctor stands and talks to you. This is going to be a collaborative. We're going to work together to solve problems. Come join us for an interesting event and something that might actually be a game changer in how we move forward as an organization and as a ecosystem that has to deal with some major challenges coming up. The more we diagnose, the more people that are going to be engaged in healthcare. The more people that are engaged in healthcare, the more important it's going to be to make sure everybody has good coverage and everybody can afford it. So we need to be thinking a little bit bigger about how do we build a sustainable future for our community. So I encourage you to get involved in the conversation and try to help you make your lives a little bit easier and your communities a little bit safer and stronger. I will be in Tampa this next month. I will also be in Indiana, so look for meet and greets in those areas, site visits, new sites coming on board. Everybody, yeah. Alex, anything people need to know about UPenn? Anything going on there? Any trials you're recruiting for? Anything you want them to know?
We are currently recruiting so there's the Edgewise trial, which is a cardiac myosin modulator. So it's not a myosin inhibitor. It's this different kind of medicine. And that's both obstructive and non-obstructive HCM. We have the Sonata trial, which is the SGLT1/2 inhibitor that we talked about earlier. That's non-obstructive and obstructive HCM. There's another, this is called Sotacross, which is similar to that one that Charlene Day is also recruiting for, which I think is just obstructive HCM. Those are the main ones I'm thinking about now. Or if you just want to come see us just to see us and not be in a trial, you can come see us too.
You can come see you too. And your directory listing has how to contact you. And I think that's all we need to do today. When in Tampa, I'll be there the first week of June. It's going to be a very small meet and greet because we just had a big organized meeting in Orlando. So a lot of people got to come out and see us for that. But if you were in the Tampa area and didn't get a chance to come over to Orlando, we'll do a small meet and greet there. Stacy's organizing that right now. It's actually 2 weeks away. Gosh, that's faster than I thought. Oops, we should have probably put that one out sooner. Sorry. And then we'll also be out in Indiana, Indiana. Okay, I'm trying to think of anything else we got to tell everybody. I don't think so. Happy Memorial Day weekend. Happy belated Mother's Day to everybody. I didn't do a podcast that week because I was traveling. Our shout out to Esther once again for good energy and healing her way. If you are a transplant patient on the pathway to transplant or post-transplant, remember the transplant pathway meeting meets twice every month. If you're engaged in any other one of our programs on our discussion groups, check the calendar. Summer hours do change a little bit because people have vacations coming up. So just keep a tab on the calendar. There's going to be new ambassadors joining us soon. There's going to be new discussion groups coming this fall. If you have any discussion groups that you'd like to see formed, please let us know, and we'll see what we can do about finding like-minded individuals to join you there. Alex, I hope you have a wonderful holiday weekend. Are you off this weekend or are you working?
I am very much working. It's okay. Someone's got to do it.
Somebody's got to do it. I'm sorry. Thank you.
Okay.
All right. Everybody, thank you for joining us on this edition of Tales from the Heart. Thank you to our sponsors. Thank you to Joey, podcast editor, for putting this together, and Ross for dropping links, and my entire team here at the HCMA who keeps the boss sane. Thank you guys. Have a great holiday weekend.
The Hypertrophic Cardiomyopathy Association would like to thank our sponsors, Cytokinetics, Bristol Myers Squibb, and Edgewise Therapeutics.